Okay, Chapter 3, Clinical Estimation of GFR and Patterns of Clearance. Okay, clearance as an estimator of GFR. Why do I care about the GFR as a clinician? I care about the GFR as a clinician because I use this as an index of renal function. The GFR tells me the severity of my patient's renal disease. The GFR tells me my patient's renal function. If GFR is decreasing, my patient's renal function is decreasing. If the GFR is rapidly decreasing, that is acute renal failure. We have rapidly progressive glomerulonephritis. You'll get more of this in the pathology section, but if there's a rapid decrease in GFR, that is acute renal failure. If there is a slow, chronic decrease in GFR, that is chronic renal insufficiency. If the GFR is increasing, that means that the renal function of my patient is recovering. So GFR tells me my patient's renal function. And this is why GFR is important as a clinician. So how do I calculate my patient's GFR? Well, I use the concept of clearance. What substances do I use to calculate GFR? Well, a couple of characteristics are important to me. I have to pick a substance that is stable in plasma, that has a plasma concentration that I can easily measure. I have to pick a substance that is freely filtered at Bowman's capsule. I have to pick a substance that is not reabsorbed, secreted, synthesized, or metabolized by the kidneys. Now, the ideal substances, the best substances to calculate GFR include inulin, sucrose, and mannitol. So if step 1 asks you, these are the substances that give you the best indication of GFR. These are the substances that are the gold standard for GFR. And if I calculate the clearance of inulin, that is the gold standard for GFR. So calculating the clearance of inulin is GFR. That's not an estimation. Calculating the clearance of inulin is not an estimation. That is GFR. Creatinine, that's an estimation. So if inulin is the gold standard for calculating GFR, why do I not use it? Well, it's not practical. So in the real world, we do not use inulin because inulin is a non-natural substance. I have to inject it in a patient. It's inconvenient. It's not a great idea, so we just don't use it. Everybody has creatinine. Creatinine is easy because everybody has creatinine, so we rely clinically on calculating creatinine clearance. It's more practical, and in the real world, we use creatinine clearance to calculate GFR. Where does creatinine come from? Creatinine is a breakdown product of skeletal muscle. Skeletal muscle is broken down every day, so this is where creatinine comes from. It's released from skeletal muscle breakdown at a constant rate, and that is proportional to skeletal muscle mass. Creatinine is freely filtered at the glomeruli. It is not reabsorbed. Now, a very small amount is secreted into the proximal tubules. Because you have a large amount of skeletal muscle being broken down, your renal plasma flow has a high concentration of creatinine entering the kidneys. You filter 20%, the other 80% goes around to the proximal tubules, and you're secreting. You're secreting well past your transport maximum, so therefore, most of what you clear of creatinine is filtered. So because you're secreting well past your transport maximum, most of what is cleared out of that total renal plasma flow is the 20% that is filtered. So this is why we say that we secrete a very small amount. Same idea with high concentrations of PAH. Because you always have a high concentration of creatinine in the renal plasma flow entering the kidneys, you're always secreting well past the transport maximum. So therefore, the amount that you're secreting is minuscule. So when we calculate the creatinine clearance, we say that we are estimating GFR. A small amount of what is cleared is actually secreted, so we ignore that amount. But just realize that when we calculate creatinine clearance, we are overestimating GFR because we have to account for that small amount that is secreted. So if they give you a question where they give you the filter load of creatinine is 140 milligrams per minute, what would you expect the excretion rate of creatinine to be? Well, the excretion rate is going to be slightly above that filter load. It has to be above because you are secreting, right? If you're secreting, the excretion rate has to be greater than the filter load, but it's not going to be much greater. So, for example, 150, 160 milligrams per minute, that would be the excretion rate for that example. It has to be above, but it's not going to be much higher. So again, when you calculate the GFR, you are slightly overestimating because you have to account for the amount that is secreted, but it's a small amount, so we ignore it. Again, this is an estimation of the GFR because you do have a small amount that is being secreted. So this is a classic graph, and it's very important to understand this. You might see this graph on the exam. They might give this to you. When you get a graph, look at your x-axis, look at your y-axis. Down here, on the x-axis, they're giving you GFR. On the y-axis, they're giving you serum creatinine. So here's your normal GFR right up here, around 120. That's your normal GFR. Now look what happens. As your GFR drops, notice as your GFR drops, your serum creatinine doesn't budge. You're not going to see an increase in your serum creatinine until your GFR is all the way down at about 60 milliliters per minute. So you have to have a pretty big decrease in your GFR until your serum creatinine increases. And that's the relationship between GFR and serum creatinine. What does that mean? That means that serum creatinine is a pretty poor index of GFR. That means that following the serum creatinine does not give me a great indication of GFR. So I do not like to use that as an indication of GFR because I do not want to wait until my GFR is 50% normal until I know that my patient is at 50% renal function. That's not a great idea. That would not make me a very good clinician if I didn't know my patient was filtering at 50% until that's a little too late. So this is why we do not like to use serum creatinine. Now, why does this happen? Your serum creatinine is not only a function of GFR. Your serum creatinine is a function of where it's produced as well as where it's removed. The kidneys remove it, but remember, where does it come from? Where is creatinine produced? Skeletal muscle breakdown. Creatinine is produced from skeletal muscle breakdown. Okay, so your serum creatinine, that's a function of GFR. In addition to GFR, skeletal muscle breakdown. And everybody has different muscle mass. Everybody has different metabolism. Everybody has different rates of skeletal muscle breakdown. For example, a 90-year-old man with very low muscle mass should have a very low serum creatinine. A younger man with higher muscle mass should have a higher serum creatinine than that 90-year-old man. So different people with different muscle mass should have different serum creatinine. So you always have to factor in your muscle mass and your skeletal muscle breakdown into the serum creatinine. And it's just not practical to do that. So this is why calculating the creatinine clearance is the best indice of GFR, not serum creatinine. This is an important graph to know and understand, and they might just give you this graph on the exam, so make sure you understand this. This graph very nicely summarizes the clearance patterns of substances that we spoke about. So once again, let's take a look at your plasma concentrations on the x-axis in milligrams per deciliter, and then on the y-axis we're looking at the clearance patterns of different substances. Let's start with inulin. Inulin is freely filtered, not secreted, not reabsorbed. The clearance of inulin is GFR. Notice, as you increase the plasma concentration of inulin, notice it stays constant. That's because the filtered load never changes. The filtered load for inulin is equal to the excretion rate of inulin, always and forever. Inulin does not have any carriers because it's not reabsorbed, it's not secreted. So nothing gets saturated here. You're not dealing with saturation kinetics. It's quite simply filtered and excreted. Filtered and excreted. There's no saturation kinetics for inulin. So therefore, the clearance of inulin never changes. It's constant. The clearance of inulin is the 20% of the renal plasma flow. That 20% is a constant value. That 20% never changes. No matter how high the plasma concentration is, the clearance of inulin is always that 20% that is filtered. Bottom line. Here's creatinine. Notice the clearance of creatinine is slightly higher than the clearance of inulin, just slightly. Why? Because it is secreted. That slightly higher clearance is the little bit that is secreted. That's creatinine. Let's look at PAH. At low concentrations of PAH, you are calculating the renal plasma flow, 600 milliliters per minute. That is the renal plasma flow. Why? Because when pH enters the kidneys, you filter 20%, you secrete 80%, you clear 100%. You clear every single pH molecule that enters the kidneys. Your clearance is very, very high. All cleared. As you increase the plasma pH concentration, the clearance decreases and approaches the clearance of inulin. Why? Because your carriers responsible for secretion of PAH become saturated. Once they become saturated, you no longer can secrete all the PAH, and what you're not secreting, you're not clearing. What you're not clearing remains in the plasma of the renal vein, and now the plasma leaving the kidneys in the renal vein contains a higher concentration of PAH. Therefore, the clearance is decreasing, and it approaches inulin. But it never equals it. Why? Because you always have the transport maximum. You always have that small amount that you are secreting. So you're always secreting a small amount. Now, the clearance never goes to zero because you always clear what you filter. The 20% that you filter plus the transport maximum, the little bit that you secrete, is cleared because you don't reabsorb it. So whatever is filtered, whatever is secreted, is cleared. It's removed. Now for glucose. At low glucose concentrations, all the glucose you filter is reabsorbed, and the excretion rate is zero. Therefore, the clearance is zero. You clear no glucose. Whatever enters the kidneys, leaves the kidneys. You filter it, you reabsorb it, your clearance is zero. Okay, what is this number right here? What would you call this number right here? If you're saying renal threshold, you are correct. If you're saying anything else, you are incorrect. The answer is renal threshold. That is the plasma glucose concentration at which the SGLT2 carriers first start to get saturated. This is when you start to excrete glucose in the urine. Now you start to have an excretion rate, and now your clearance starts to increase. Now you actually are starting to clear glucose. Why are you clearing it? Because it's leaving the kidneys. Now if you look at the plasma in the renal vein, the plasma that is leaving the kidneys, you start to see glucose. If you see glucose that appears in the renal vein, you're not clearing it. So now the clearance of glucose is actually increasing. You're not clearing it. Why? Because your carriers are saturated. You are no longer able to reabsorb all the glucose you're filtering. So you're no longer reabsorbing all the glucose you're filtering. So you're excreting glucose. So you're clearing it. If you're excreting it, you are clearing it. So now it increases. So now the clearance increases and it approaches the clearance of inulin. And these are the clearance patterns. So to summarize clearance from highest to lowest, PAH at low concentrations has the highest clearance pattern. Filter 20%, secrete 80%. You clear all the PAH, followed by creatinine, then inulin. Inulin somewhere in the middle. Then urea. Okay? Remember, urea is filtered and urea is reabsorbed. Urea is reabsorbed, however, urea is poorly reabsorbed. Urea is filtered, urea is reabsorbed, however, urea is poorly reabsorbed. Then sodium. Greater than 99% of the sodium you filter is reabsorbed. Then glucose. If you're not hyperglycemic, you reabsorb 100% of the glucose that you filter. Albumin you don't even filter. So I want to make one important point here. Creatinine. inulin, for example. The clearance of inulin and the clearance of creatinine is not so great. It's terrible. The clearance of inulin is 20%. The clearance of creatinine is a little bit greater than 20%. Imagine if you took an exam and you got 20%. Would you be happy with that? Would you be happy with getting 20% on an exam? That's a terrible number. So the clearance of these substances, they're pretty terrible. But as a clinician, that's what we care about. Because the clearance of these substances tells us GFR. And as a clinician, all I care about is GFR. I don't care about the renal plasma flow. Renal plasma flow has no clinical implications to my patient. My patient is never going to come in and say, hey doctor, what is my renal plasma flow? I'm just curious. Can you please tell me my renal plasma flow? I just want to know what it is. They don't care about that. They do care about their GFR, because if they go into renal failure, they're going to care. So GFR has very important clinical applications to me as a physician and my patients when they go into renal failure. So that's why we care about inulin clearance and creatinine clearance, because of the clinical implications. And we really don't care as clinicians about PAH clearance. You have to care for step 1 because you will be questioned on it, but I just want to be clear on clearance. The clearance of creatinine and inulin is not so great, only 20%, but they are very important to us because when we calculate the clearance of these substances, they tell us a very important value for patients. They tell us a very important clinical application, GFR. And that's why they have clinical applications. And that's an important concept. So remember, if a substance is in the renal vein, it is not cleared. Albumin, glucose, they're not cleared. And this is an important concept to understand. And that is clearance. Are you clear on clearance? The next concept is the concept of free water clearance. So, let's say you go eat a bag of potato chips, or you go to McDonald's and you get a bunch of French fries. You're eating a lot of sodium. So as soon as you eat that sodium, you have an increase in your serum sodium concentration, and you have an increase in your serum osmolarity. So, your serum osmolarity ranges anywhere from 280 to 300. The second your serum osmoles go to 301, that's it, that's all you need, the osmoreceptors in the hypothalamus will sense this and lead to an increase in secretion of ADH. ADH will lead to an increase in reabsorption of free water from the collecting ducts. So now you will be reabsorbing more free water, and you will be excreting less free water, because you will be reabsorbing more free water from the collecting ducts, and the more free water you reabsorb, the less you are excreting. So you will have less excretion of free water. Now, we call that the free water balance. Now, if you are reabsorbing more free water, you are clearing less free water. So we would say you have a negative free water clearance, because what you are reabsorbing, you are not clearing, or you are not excreting. So, if you have a negative free water balance, you will be reabsorbing more free water, and that means you will be clearing less free water, and you'll be excreting less free water. And that will give you a hypertonic urine. So you will see a negative free water balance will tend to give you a hypertonic urine, because there's less free water in the urine, there's more free water being reabsorbed, and you are clearing less free water. In a positive free water clearance, you have low levels of ADH, so that means you are excreting more free water. Because you are excreting more free water, you will have a more hypotonic urine form. So a positive free water clearance will give you hypotonic urine, because you will not be reabsorbing free water. And we call it a positive free water clearance because you are now clearing more free water from the kidneys. You'll tend to see that when you have a low osmolarity. So here's a sample calculation for calculating the free water clearance. Here you see the urine flow rate is 3 milliliters per minute, the urine osmolarity is 800 milliosmoles per liter, and the plasma osmolarity is 400 milliosmoles per liter. So if you calculate this equation, you take the urine flow rate, which would be 3 milliliters per minute, and you subtract that from the urine osmolarity times the urine flow rate over the plasma osmolarity. And if you calculate that, you will see that comes out to be 6 milliliters per minute. 3 minus 6 milliliters per minute will give you a free water clearance of -3 milliliters per minute. -3 milliliters per minute, that is what we call a negative free water clearance. The conclusion here is that the kidneys are conserving water. The kidneys are appropriately reabsorbing water. This would be in response to excessive plasma osmolarity due to ADH. And this is what you would see with a negative free water clearance. Increased reabsorption of free water in order to keep the plasma osmolarity in the normal range. So this is a sample calculation of free water clearance. Sodium clearance. Almost the entire filter load of sodium is reabsorbed, so its clearance is just above 0. Aldosterone plays a major role in increasing reabsorption of sodium and decreasing its clearance. Now, sodium is freely filtered at Bowman's capsule. 67% of the sodium that is filtered is reabsorbed in the proximal tubules. About another 20% is reabsorbed in the thick ascending loop of Henle. About 5% is reabsorbed in the distal convoluted tubules. About 25% is reabsorbed in the thick ascending loop of Henle. And in the collecting ducts, about 3% of sodium is reabsorbed, and that is based on aldosterone levels. So reabsorption of sodium in the collecting ducts is completely dependent on aldosterone levels. So as there is an increase in aldosterone levels, there's an increase in reabsorption of sodium from the collecting ducts. Atrial natriuretic factor plays a very important role in natriuresis and diuresis. What atrial natriuretic peptide does is it is secreted in a high volume state when there is stretch on the right atrium. And that will lead to vasodilation of the afferent arterioles and vasoconstriction of the efferent arterioles. It also will directly suppress renin release. Now, the net effect of ANP is to increase GFR, increase filtration of both sodium and water without reabsorbing later on in the nephron. And that will lead to both a natriuresis and a diuresis, and that will lead to loss of volume in a patient with a high volume state. So ANP is secreted in high volume states, and that leads to diuresis and natriuresis to get the volume back down to normal. Aldosterone is the opposite. Aldosterone is secreted in a low volume state, and that leads to an increase in reabsorption of sodium in the collecting ducts to preserve volume. Urea clearance. So urea is an important solute to speak about. Urea is freely filtered at Bowman's capsule, but partially reabsorbed. Now, it's very important to understand this because urea is excreted, but not secreted. So urea is filtered and then partially reabsorbed. The reason why urea is excreted is because it's very poorly reabsorbed. It is reabsorbed with free water, but disproportionately, meaning more free water is reabsorbed than urea. So as you go through the nephron, the concentration in the ultrafiltrate of urea increases, ultimately leading to excretion of urea. Now, here's a very important concept. ADH increases reabsorption of urea in the inner medullary collecting ducts, and that leads to an increase in BUN. And that's a very important clinical indication for us. When patients have acute renal failure, we look at the BUN to creatinine ratio. If the BUN to creatinine ratio is elevated, that tells me that the patient has pre-renal azotemia because that patient is dehydrated, ADH levels are increased, and ADH leads to an increase in reabsorption of urea, leading to an increase in BUN. So if I have a high BUN to creatinine ratio, that tells me my patient is dehydrated. Therefore, what you're going to see is an increase in BUN, an increase in urea in the renal plasma, leading to a decrease in its clearance. Therefore, ADH leads to a decrease in the clearance of urea because more urea is reabsorbed in a situation with its high ADH levels. When urea is reabsorbed, a lot of the urea sits in the interstitium of the medulla. We call that urea recycling. That urea that sits in the interstitium, that adds to the corticopapillary gradient. And the corticopapillary gradient is responsible for increased reabsorption of free water from the collecting duct. So in order to reabsorb free water, you need two things. You need permeability, but you also need a cortical papillary gradient. And ADH adds to that gradient by increasing the reabsorption of urea, which sits in the interstitial medulla and increases the cortical papillary gradient, leading to an increase in reabsorption of free water.